welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Shankari Sureshbabu, who is a PGY2 in emergency medicine at North Kansas City Hospital. She is going to be presenting on a journal article titled Comparison of Nebulized Ketamine to Intravenous Subdissociative Dose Ketamine for Treating Acute Painful Conditions in the Emergency Department.
Objectives for this presentation. The first one is just to understand the background and data behind the use of ketamine for the treatment of acute pain. And the second is to actually evaluate the trial that looks at the efficacy and safety of IV ketamine to nebulized ketamine for acute pain. So I think we're all familiar with ketamine, but specifically for acute pain, the mechanisms that we anticipate that are used are basically the fact that ketamine is an NMDA antagonist, a mu opioid receptor agonist, and a GABA agonist. And patients that would be considered good candidates for treatment with ketamine are patients that are undergoing surgery with severe expected post-op pain, patients that could be opioid tolerant or dependent and you don't want to use opioids for them, or patients that are at an increased risk for opioid-induced respiratory depression. I think we are most familiar with IV ketamine for the most part, but so nebulized ketamine, I figured I needed a bit of a background. So nebulized ketamine, some pros are that it can be used for patients where IV access is not available or unobtainable. It's not invasive, so that's a pro for sure. Based off of previous trials that I've seen, the bioavailability is estimated to be about 20 to 40% of the IV route. This is basically calculated with an expected duration of about 20 to 40 minutes of inhalation. Other studies and the group that I specifically found this journal club from, they actually had studies on ketamine previously, and those have demonstrated analgesic efficacy with a lack of serious adverse effects. So one of the trials that they looked at previously from the same group was comparing different doses of this nebulized ketamine at 3 different dosing regimens. So they looked at patients that got 0.75 mg per kg, 1 mg per kg, and 1.5 mg per kg. And what they saw was they all were equally efficacious and there was no real difference in efficacy seen. So ideally, we'd use the lowest dose possible as that's the lowest dose necessary. This trial and the trial previously actually used an interesting product that I hadn't heard before. It's called the breath-actuated nebulizer. So unlike the continuous nebulizers that I think that we're most familiar with, this is a little bit different. So a continuous nebulizer, we assume, is just a continuous release of this aerosolized mist that's just going in at a continuous rate. But a breath-actuated nebulizer, or a BAN, basically only releases the mist when a patient takes in a breath. So it's supposed to be better suited because a patient can have a bit more control into their own pain relief. We're not wasting meds by having it continuously mist when they're actually not using it. And these patients aren't getting ideally like too high of a dose because they, once again, have a bit more control. The figure on the right is from a certain specific product, AeroClips, that is a breath-actuated nebulizer. So in the figure 1, you can see like when a patient is taking a deep breath, they have this mist going into their mouth, as opposed to number 2, when they're not inspiring, they don't have this medication actually go in. So I think that was good background. So let's move on to the actual trial. So the title of my trial was Comparison of Nebulized Ketamine to IV Subdissociative Dose Ketamine for Treating Acute Painful Conditions in the ED. In terms of design, the objective was to assess and compare the analgesic efficacy and adverse effects of these 2 dosage forms. It was done at a single center urban community hospital in New York City. It was a single center trial. It was randomized, double blind, and since they used 2 different dosage forms, it was also a double dummy trial. The 2 interventions were the IV ketamine. I'm going to call this the IV SDK group because it's the subdissociative dose. They were given 0.3 milligrams per kilogram over a 15-minute infusion. And then the nebulized ketamine group, they were given 0.75 mg per kg through this breath-actuated nebulizer, like I just mentioned. You can see how their past trials seem to kind of lead to the dose they chose in this trial. They could see that the lowest efficacious dose essentially is what they chose to move forward with in this trial. Continuing with study design, they included patients that were above the age of 18, that presented to the ED with an acute painful condition that was rated at a 5 or higher, they used the numeric rating scale, so the ones where the patients kind of articulate their pain on a scale of 0 to 10. And they also, since it was heavily dependent on patients being able to verbalize and articulate the pain they felt and also any adverse effects that they might feel, they wanted patients that had the ability to verbalize this information. Exclusion criteria, they excluded a good number of patients. So patients that they figured needed immediate intervention for their pain, those were excluded. Any patients that were altered, any unstable vital signs, acute intoxication, they're also excluded. Since we are doing a milligram per kilogram like weight-based dose, they capped the weight limit at 150 kilograms. And they also excluded patients that had a past medical history of alcohol or drug abuse or pregnancy and breastfeeding. In terms of methods, I thought this is actually very interesting because the ED pharmacist had a very special role to play in this trial. They looked at patients between the time of October 2021 to September 2023, specifically between the hours of 8 a.m. to 8 p.m., Monday through Friday. You might think that's very specific, but it's actually because the ED pharmacist was unblinded to this trial. They were the ones that prepared both of the doses and also the double dummy placebos. So it was just when the ED pharmacist was available, essentially. So in terms of the placebos, the corresponding placebo to the IV solution would be the 100 milliliters of normal saline. And then for the nebulizer, the pharmacist would make nebulizer that was filled with normal saline solution as well. In terms of dosing and delivery, it seems like, as I mentioned, the dosing administration that they chose were derived from this earlier published data that they found from the specific group. For the IV group, they infused it over 15 minutes. And for the nebulized group, I think they kind of wanted to match that same time frame. So they did want patients, since it is patient-directed, it's a little harder, but they wanted patients to use this medication for at least 5 minutes, up to a maximum of 15 minutes. In the protocol, they also mentioned that they did intend for a specific rescue analgesic, specifically IV morphine was the one they recommended. In terms of endpoints, the primary endpoint for this trial was a between group difference in pain score on the numerical rating scale at 30 minutes after ketamine administration. Okay, so secondary endpoints were need for rescue analgesia, occurrences of adverse effects in each group, and then differences in pain scores at different time points. So they started at 15 minutes all the way down to 120 minutes. So they wanted to kind of see the difference in how long it lasted, how soon it started, essentially. In terms of statistics, they had listed at the very beginning that the minimal clinical significance that they would consider, the minimal difference between groups that they would consider clinically significant is a difference of 1.3 points on the NMS. They estimated a required enrollment of 67 patients in each group to meet 80% power, and they adjusted that just to account for patients leaving early to 75 patients in each group. And all the data was conducted on the intention to treat population. Looking at baseline demographics, I think that the two groups are well matched. So the left-hand side is the IV group and the right-hand side is the nebulized group. I think they're well matched for everything. Both groups seem vitally stable. I also appreciated that both groups had a significant amount of pain. I think when we're looking at a study that's, documenting or looking at pain relief, it's important that they actually are in pain to see how much it actually is efficacious. Continuing with baseline demographics, it seems like most patients that came in and presented had abdominal pain, and the second seems to be different types of musculoskeletal pain. But these two groups are also well matched for that. In terms of actual results, this is a big table with a lot of numbers. So on the very left, I'll help orient. The very left is the time frames that we're looking at. The first row is baseline pain reported, and each row below that is a time frame or time point as we go further into the study. The first couple columns are the IV group, and then the next are the nebulized group. You can see that in the beginning, the 8.2, pretty high levels of pain. Even within 15 minutes, this pain has been knocked down a good amount. In the IV group, you see about 2.6 for 15 minutes and about 3.8 in the nebulized group. You can see that there seems to be a slight difference here. It still isn't within the 1.3 that they would consider clinically significant. There is probably a difference in the onset between these two routes of administration, so that can account for that. But at the end of the day, this isn't the primary outcome. The primary outcome would be the 30 minutes. At the 30-minute mark, you can see that these numbers have become more similar, 3.6 in the IV group and 3.8 in the nebulized group. So it seems like at the primary outcome, these patients basically have no difference in their pain levels if you use either groups. As we go down the line, like further into the study, there do seem to be more fluctuations between the groups, but at no point does it seem to be that one group is clearly more efficacious than the other. So I thought this was an interesting graph that they provided as well. It essentially just tracks from baseline to the primary outcome of 30 minutes, patient's pain scores. So the y-axis on the left is showing the pain scores, the severity of the pain scores. The higher ones are more pain, the lower ones are less pain. And the left-hand side with all the orange is all of the IV groups, and the blue is all the nebulized groups. The top numbers here are, like the top lines are the patient's initial pain scores. And then when they ask them again at 30 minutes, they ask them what their pain is, and this is their score. Like the bottom of the line is like what their score was at that 30-minute mark. I thought it was interesting to see the data visualized in this way. It does seem like they have fairly similar efficacy between both groups, but I think it's interesting to note that there are a lot of patients that seem to go all the way from, like, let's say like a 10 initially all the way down to 0 in the IV group. And it seems like that patients coming back down to a pain score of 0 seems to be more common, specifically in the IV group than the nebulized group. Not statistically, but I just thought it was interesting. Patients did also receive rescue medications, like I mentioned. Initially, they did want to, in the protocol, they wanted everyone to receive morphine, but in actuality, this didn't end up actually happening. I think only a handful of patients received morphine as their rescue med. It actually seems that the K-band group received much more or more frequently rescue meds than the IV group. The IV group, as you go further into the study, kind of makes sense. Maybe the effects of ketamine are wearing off. They're requiring more and more rescue analgesia. And the K-band group is even more severe in this way. So within the first 30 minutes or so, it's only a couple patients that receive it. But by the time that we get to the 90-minute mark or the 120-minute mark, it seems like a considerable amount of patients are actually requiring rescue analgesia. I appreciated that they did a per protocol analysis because I did want to see if the rescue analgesia was kind of confounding these numbers that we looked at before. It doesn't seem to affect the primary outcome because that's 30 minutes and most patients didn't receive any rescue analgesia at that point. But the later timeframes, it did receive a lot more. They did seem to receive a lot more. So this per protocol analysis looked at all the patients that did not receive any rescue meds or only received morphine as per the protocol. So when we look at the primary outcome of 30 minutes at this point, only one patient in either group had received IV morphine at this point. So only one of them would maybe have received any rescue meds. And you can still see that in this group, there is not statistically significant difference between the pain scores in either group. So I felt like that gave me a bit more of a vote of confidence, essentially, that both of them really are efficacious. In terms of adverse effects, the most common adverse effects that were reported were fatigue, dizziness, and headache. Overall, there seemed to be minimal rates of mood change, hallucinations, hearing, or vision changes in both groups. There was more reported sedation, restlessness, and dizziness in the IV ketamine group, but overall, it didn't seem like there was any severe or serious adverse effects. They all seemed to be pretty mild, and nothing was considered clinically relevant. There are also no clinically concerning changes in vital signs in any of the groups. In terms of authors' conclusions, they found that there was no difference found between the administration of IV and nebulized ketamine for short-term treatment of moderate to severe acute pain. But I wanted to talk and discuss a little bit more. I think the strengths of this trial, I do think that it's a novel study question. I don't think that there's many trials that look and compare IV ketamine to nebulized ketamine. And it's maybe helpful to see a potential route that would spare patients from getting these IV medications. Also, because it's not an opioid, it could be considered like an alternative to opioids also. So that's a benefit as well as a treatment option for acute pain. I do think that in terms of how the study was laid out, it was well-matched patients with high levels of acute pain in both groups. Both the intention to treat group and the sensitivity analysis seem to be well-matched. I think gives me a vote of confidence in that way. And they did a good job of trying to blind as many people as possible. So physicians, nurses, study investigators, and patients were all blinded to the treatment options. So that was helpful. In terms of limitations, I do think there are a few ones that I found interesting. There are a large number of patients, like I mentioned, that were administered rescue analgesics. This could obviously confound the results. I think the sensitivity analysis did a good job of incorporating that, but as the study went on, more and more patients did receive rescue analgesia. And I think that even if we did incorporate only the morphine in the sensitivity analysis, I would have found it interesting if we had a group that just didn't receive any rescue analgesics, just to see how those patients fared. Then I also think that there is, because we're using ketamine, some operational concerns that they didn't really touch on in this study. So the K-band group, essentially, like I mentioned, one of the pros is that it is patient-directed and patients can basically choose how much medication they're getting because they have to essentially control themselves breathing in the medication. But this also leads to the potential for not really knowing how much patients are not using. Like, this group did not choose to document how much patients compliance or how much they wasted. They didn't talk about like the operational tasks of wasting the medication afterwards or disposal of it. I think that that's maybe in the real world something that operationally would be something that trips up or like is something to take into consideration when we use nebulizers or K-bands. They, like I mentioned, did not assess the treatment time in the ketamine nebulized group either. So it said that they wanted these patients to use it from anywhere from 5 minutes to 15 minutes, but there isn't any record of how long these patients actually ended up using it, how compliant they were with the medication. And since the dosages would obviously vary between patient to patient when they are able to direct it themselves, this could also potentially confound like how much ketamine they actually got and how effective that actually was. Lastly, that's basically what I mentioned. There are differences in nebulized treatment doses as they're patient-directed. So the summary for the entire trial, basically, I think that both IV ketamine and subdissociative doses and nebulized ketamine can be considered effective treatment options for moderate to severe acute pain. I do think there's pros for both sides. For the IV group, you can see that they usually seem to have a faster onset of action. We can use lower doses of ketamine overall, and there seem to be lower rates of rescue analgesia needed in these groups compared to the nebulized group. But the nebulized group is also an option, especially for patients that you don't want to give medications IV. It's a non-invasive route. And I think the novel idea of it being patient-directed pain control, I think, is also really interesting. So I think that they both have good options. But that was the end of my trial. If anybody have any questions, please let me know.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.